lying, right? Left side lying being the best for a woman. The other point to point out about blood is that when a woman is pregnant, we consider pregnancy to be a hypercoagulable state. So what does that mean? So you've got it if you started to think form blood clots, right? Pregnancy is a hypercoagulable state. She remains hypercoagulable for the first 6 weeks postpartum, which is also important to remember. So hypercoagulable state, and I'm sorry it doesn't show up here, but you can see from your notes, right? Because they have an increase in fibrinogen, they have a decrease in fibrolytic activity, and the platelets slightly decrease as normal pregnancy. But your big take home is more prone to clots, hypercoagulable when someone's pregnant. So this is showing you on someone's leg what a DVT would look like. So redness, swelling in the calf compared to the other calf. So you just want to be mindful that if you're caring for a woman during her pregnancy, we're really, really quick if we see any symptoms of a DVT to make sure we get an ultrasound of that leg and check it out. So just be aware. Other changes that happen when someone's pregnant, they get what's called the linea nigra, which is the line that's here on this woman's belly button. That's a normal pigment change of pregnancy. It usually fades once somebody delivers and, in the postpartum period, but it does happen. Some people get what we call this mask of pregnancy. We call it a chlasma or a mask of pregnancy, so this rash here on this woman's face. And then the other thing that can happen is stretch marks, and sometimes those are hereditary. They sell all the creams in the world, but really if somebody is going to get them, they're going to get them. What I think plays into skin is nutrition and hydration. So the more well-nourished with a healthy diet and drinking a lot of water somebody is, the better their skin does during pregnancy. And I will also say that's hugely important related to tearing. So the tearing that somebody can get a laceration on their perineum. My patients with better nutrition tend to tear less, which is just a really good thing to think about. So eyes, ears, nose, mouth, throat. It's not a good time to have an eye exam when you're pregnant because you get a little bit of eye changes. So we recommend in the postpartum period to go and get your eye exam. And nasal congestion is cut off there, but many people have a worsening of allergies when they're pregnant. And most pesky symptoms that we're going to talk about, side effects of pregnancy, have to do with progesterone, which is great, keeping the baby alive, but it causes side effects. This one sort of, pregnancy physiological change, this congestion of somebody's nose, is actually caused by the estrogen. So estrogen is causing that. So GI changes are really big in what most women complain about during pregnancy. And typically what that is that women, when they are pregnant, because of the progesterone, I'm talking about early pregnancy, so first trimester. We're talking about the first 12 weeks of somebody's pregnancy when we talk about the first trimester. In this span of time, the progesterone is so high keeping her baby alive, which is absolutely wonderful, but the progesterone causes her to feel nauseous. So what the progesterone is doing, and sometimes I'll say to patients, I'm like, look, the same thing that's keeping your baby alive is giving you all these side effects. I'm really sorry. But sometimes it just helps people to understand what's happening. So when somebody is pregnant, they are going to have a slight delay in their gastric emptying time. And that's really because the body wants to absorb all the nutrients it can to get that into the bloodstream, into the fetus. So that's what that slight delay is. Many women, when they're pregnant, are going to be prone to getting heartburn. Tums are totally fine to take when somebody's pregnant. Avoiding spicy foods, that sort of thing will help. With the nauseousness, it is a really important thing to educate people. If your stomach is empty, you are nauseous because of all the gastric acid that's in your abdomen. So you need to eat in order to feel less nauseous. So a pregnant woman who's nauseous in her first trimester isn't going to want to hear that news. So what I tell people is 6 small meals a day. So wake up in the morning, have a yogurt, have some crackers, something light, and then 2 hours later, eat a snack. So break up your normal 3 meals into 6 small meals throughout the day. We actually all should be eating that way from a blood sugar perspective. It's just who has time to. But the pregnancy diet is the healthiest way to eat, 6 small times a day. All right, endocrine. So if somebody, when they're pregnant, they have a slightly enlarged thyroid gland. The other thing that happens is their blood glucose levels are slightly lower. And we want to think about why that might be. So the reason, if you thought of it, is because that sugar is trying to get to the baby. So mom's levels are a little lower because the free-flowing sugar is going to the fetus. She's also a little bit less sensitive to insulin. Again, that's all the body physiologically saying, I'm going to be a little less sensitive to insulin so that the baby can get more sugar. So the sugar in my body, those molecules stay and get to the baby. We will talk in depth about gestational diabetes, so don't worry about that right now. The urinary system we talked about, you saw the picture, you know she's going to be going to the bathroom more frequently. It makes sense when you think of what that uterus is doing. There is a risk for hydronephrosis if the kidneys or ureters become obstructed. There would be a risk for hydronephrosis. Not a normal complication. The normal is just the increased frequency in urination. Neurologically, women get headaches, especially in their first trimester. That is completely normal. Again, caused by our friend progesterone, a lifeline of pregnancy, but it's causing them to get headaches from the vasodilation that progesterone causes. Other thing that's in your handout, sorry, cut off here, is people get a numbness and tingling of their hands. So it's like a carpal tunnel, and that's common in pregnancy from all the increased blood volume, guys, pushing on their radial and ulnar nerves. Their hands get numb. It goes away after they have the baby. They can wear carpal tunnel braces if they want, but that can be a normal change of pregnancy. All right, musculoskeletal. We talked about that round ligament, our first class, and how that can cause a sharp shooting pain that comes and goes. It only lasts for a couple seconds. It's not a long sustained thing. We will talk about how that's very different than a contraction. We also talked about lordosis at the start of class. It's the curvature change of her spine, and I have that on the next slide, which I'll show you better. Her symphysis pubis, right, that the bone that I told you guys can all feel in your own pelvis, that sort of widens to make more room in her pelvis. Here's a picture of lordosis in action. So here's your spine early on, non-pregnant. Here it is when she's, mid-pregnant, and here it is when she's full term. So you can see how drastically that changes in order to support, our friend, the developing fetus. So the hormones you can go through and review from yourself from our first class. HCG is what's secreted when somebody's pregnant, and that's what's going to show up in a pregnancy test. And those can be by urine or they can be by blood. The urine is a qualitative test, right? And then if we do it by blood, we get quantitative data. We actually get a number. Estrogen, progesterone, you want to look at in context of this class and our first class. And then relaxin is also a hormone that's made during pregnancy to help relax the joints. So that helps support lordosis, helps that widening of the symphysis pubis. So really, really big thing that we're going to talk about when we talk about nutrition, we have a whole class on nutrition for pregnant women, is that when somebody's pregnant, they need to gain weight. And for a woman of a normal BMI, when she enters her pregnancy at a normal BMI, which ideally is how everyone should enter their pregnancy in the most ideal health, that woman should gain 25 to 35 pounds. We'll go through the algorithms of, who should gain more, who should gain less based on their BMI on the next slide. But right here, you want to just look at, this becomes important. If I'm working with a client, guys, who's had anorexia or bulimia, you better bet that she's really worried about where that weight that she's gaining is going, even if she's in recovery from her eating disorder. So I use this graphic with my patients and show them, it's not you that is gaining all of the weight. This is where it's going, your uterus, the fluid, the baby. The other really, really amazing thing, her blood, guys, look at this. She's gaining 3 to 4 pounds just in the increase of her blood volume. That is quite amazing. So this graphic is really nice for women in general to see, especially women with a history of an eating disorder. This we will come back to as well when we talk about nutrition, but I leave it here to start to show you that what I had just referenced is that when we have a woman who is of a normal BMI entering her pregnancy, she gains 25 to 35 pounds as a recommendation. If we have somebody underweight, we want them gaining more. And clearly, if they're overweight by their BMI, they should be gaining less. And we'll get back to this in nutrition when we talk about nutrition as well. But this is important to understand what the weight gain for somebody of a normal BMI, underweight, and overweight is. These are definitely crucial things to know for you. So we're going to wrap up this recorded session with confirmation of pregnancy. So this is one of those things that I'm like, why in the world do we need to be labor? But ATI and NCLEX belabors these three things, so you can put this as ATI, NCLEX, make sure I study. So they really, what they're getting at here is the only way to know somebody is for sure pregnant is that she has what is in this third category, a positive indicator of pregnancy. We're going to break down what these other two categories are as well. But the only way to know for sure she is pregnant is that if she has a positive indicator. So let's break down these three categories. So a presumptive indicator doesn't mean for sure, just presumptively. Means amenorrhea. She has missed her menses. Amenorrhea. Missed period. Missed menses. She's nauseous, she's tired, she's peeing a lot, she has breast changes, skin changes. She has that Chadwick sign, right? She feels something moving in her belly. These are all just presumptively that she's pregnant, right? Nothing is saying it for sure. This next category, we move one step further. It's probable that she's pregnant. These are usually the changes that a provider would assess in somebody. So you would sort of look at these things, and even with this, I can't say for sure because a pregnancy test, whether it's by urine or blood, doesn't necessarily tell me she has a viable pregnancy. She could have an ectopic pregnancy in her fallopian tube. She can have any of the pregnancy complications that aren't a viable pregnancy that we'll talk about at a later date this semester. But anyway, just don't get confused. A pregnancy test in and of itself is only a probable indicator. This is something here that's a probable indicator. So I will come back to ballottement. And just to go back to just put a picture here, it would be a provider sort of feeling a fetal head come down into their hand when they're doing an internal exam. So how do you know that somebody is absolutely for sure 100% positively pregnant? Well, these are the ways that we could positively say it. We actually hear the heartbeat with what's called a fetal Doppler, and I'll talk more about that on Monday. The provider, so not the woman, but the healthcare provider actually feels the baby moving, by placing their hands externally. Or we get an ultrasound, and here we go. We see the fetus. So here's the head up here. There's little arm buds coming out, and here's the body. And we would see a heartbeat right in the center of the body area. So, all right. So let's end with fetal movement. So fetal movement has a good term with it. The term is called quickening. So remember what lightning was. We talked about that. This is a different term. This is quickening. Quickening is the term we use for when somebody feels the baby move, especially for the first time. So it's felt differently whether you've had a baby before or not, meaning if you've had a baby before, you're kind of aware of it and feel it sooner. So these women usually feel it around 18 weeks of pregnancy versus the prima gravida, which is somebody who's having her first pregnancy, she usually doesn't feel it till 20 weeks. Now, the big take home here is, what if the partner comes in and her partner says, but I can't feel it? Well, you reassure the partner that they usually can't feel that baby kick until about 24 to 25 weeks. Mom can feel it internally, but the partner isn't going to feel it externally for about another month until a month later from the mother. All right, and then we will pick up with prenatal care. So I want you to look through the rest of this material watch The Business of Being Born, and definitely prep the first half of the birth material because we will